So, jaundice or icterus, it's yellowish discoloration of skin, sclera, and mucous membrane. It's all about yellowness or discoloration. The jaundice occurs when we have high plasma bilirubin. The high levels of bilirubin in plasma resulted in jaundice. The normal level of bilirubin is 1 milligram per deciliter, and jaundice appears when it's more than 2 milligram per deciliter. So jaundice is always about hyperbilirubinemia. And since the jaundice is the high levels of bilirubin or hyperbilirubinemia, it's very important to know where bilirubin comes from or what bilirubin is. The bilirubin is a component of bile and coloring. It's coloring the urine and feces. And I mentioned in details the bilirubin metabolism and the bile pathway in the previous video. But quick refreshment, the red blood cells from the blood vessels when it's getting age or even after the lifespan of 120 days, or if we have abnormally shaped red blood cells, is being destructed in macrophage system or reticuloendothelial system. And the main product of this destruction is the hemoglobin. And then hemoglobin is catabolized into two components, the globin and the heme group. The globin then broken down into amino acids, and these amino acids is reutilized, while the heme group is catabolized into bilirubin. And this bilirubin is water insoluble because it's unconjugated bilirubin. Here, the bilirubin binding to albumin and transported into the liver, where the conjugation takes place. So unconjugated bilirubin inside the liver or hepatocyte through an enzyme called glucuronide transferase converts it into conjugated bilirubin. Then this conjugated bilirubin secreted into bile, and then the bile secreted from the liver into the biliary system. Then conjugated bilirubin transported into small intestine, and since there is no catabolism or process, it's not processed inside the small intestine, but passed to the colon or large intestine. Inside the large intestine, conjugated bilirubin through intestinal bacteria is deconjugated or catabolized into urobilinogen and styrocopulin. The styrocopulin secreted into stool and give the stool its characteristic color, while urobilinogen is absorbed into the liver. 10% of these urobilinogen absorbed into the liver, but only some, is escape into the circulation and converted into urobilin and to the kidney, secreted into urine and gives the urine its color. So again, jaundice, it's occurs when there is high levels of bilirubin. But as we know, there are two types of bilirubin. So the jaundice usually either unconjugated hyperbilirubinemia or conjugated hyperbilirubinemia. There are two types: unconjugated jaundice and conjugated jaundice. Again, here is the simple diagram. This is the hepatocyte where the conjugation takes place. The unconjugated bilirubin through the glucuronide transferase, the enzyme, this unconjugated bilirubin and converts it into conjugated bilirubin. The hepatocyte and through the protein called transporter protein or MRP2, this protein facilitates secretion of the bile into the biliary system. Okay, now the jaundice, it has three types. We have prehepatic jaundice, hepatic jaundice and post-hepatic jaundice. The prehepatic jaundice, where there is increasing RBC's hemolysis. This is resulted in increasing the unconjugated bilirubin, which exceed the liver capacity for conjugation and excretion. So if we have unconjugated bilirubin, high amount of unconjugated bilirubin due to increase RBC's hemolysis, which exceed the capacity of the liver, this is resulted in unconjugated bilirubin increasing level. So unconjugated bilirubin appears in blood, leading to jaunice, leading to jaundice, due to increases the amount of unconjugated bilirubin. But also, in this state, we have conjugated bilirubin higher than normal, because liver here working with its capacity, its full capacity. For example, if we have the maximum capacity of the liver to process 10 molecules of unconjugated bilirubin, in this state, it works with its full capacity. So even the conjugated bilirubin is higher than normal here. The prehepatic jaundice associated with hemolytic anemias, usually associated with hemolytic anemias, since it's happened when there is increases of RBC's hemolysis. And the causes of prehepatic jaundice, either due to abnormal RBC's shape, like what happened in sickle cell anemia and spherocytosis. In sickle cell anemia, for example, we have abnormally shaped red blood cells, and even in spherocytosis. And in this state, there is increase in RBC's hemolysis. The second cause is the mechanical destruction. And the mechanical destruction happen like what happening in the malaria, by the malaria parasite, or even in state of hyperbilirubinemia. There is mechanical destruction of the red blood cells. So we have increases of RBC's hemolysis. The third cause are other causes like transfusion reactions or even some drugs. The second type of jaundice is hepatic jaundice. And hepatic jaundice, where we have like liver cell damage or decreasing the conjugation inside the liver, or after conjugation, there is decrease of secretion of the conjugated bilirubin. So in hepatic jaundice, either we have increasing conjugated bilirubin or increasing of unconjugated bilirubin. And the causes of hepatic jaundice, for example, we have viral hepatitis. So like what happened in the viral hepatitis, or alcoholic liver disease. In this state, we have cell damage. So there is failure of conjugation, no conjugation. This leads to increase of unconjugated bilirubin. In this state, we have unconjugated hyperbilirubinemia or unconjugated jaundice. The second cause of hepatic jaundice, also we have a disease called Gilbert's disease. And in this disease or syndrome, there is a decrease in the activity of the conjugated enzyme, which leads to unconjugated hyperbilirubinemia or unconjugated jaundice. In the Gilbert disease, the glucuronidtransferase enzymes, there is decreased activity of these enzymes, which leads to decreased amount of unconjugated bilirubin. Especially, this has happened when there is for example, starvation or infection. The level of unconjugated bilirubin increases, and since there is the decrease in this activity of this enzyme, the unconjugated bilirubin increase. So another cause of um, hepatic jaundice is the Crigler-Najjar syndrome. And Crigler-Najjar syndrome, there is no enzyme. There is deficiency of the enzyme glucuronide transferase, and also we get unconjugated jaundice. And in Crigler-Najjar syndrome, the levels of unconjugated bilirubin increases due to absence of the enzyme of glucuronide transferase. Levels of unconjugated bilirubin, when it increases, this is increase the risk of what we call kernicterus, and this is due to unconjugated bilirubin. Since it's lipid soluble, it can bind to basal ganglia in the brain and cause kernicterus, which is a serious disease. The third cause or fourth cause is Dobbin-Johnson syndrome. And in Dobbin-Johnson syndrome, there is decreasing of um, conjugated bilirubin secretion. So there is already conjugation of bilirubin, but the problem in the secretion. And in this state, we have conjugated jaundice. So in Dobbin-Johnson syndrome, there is deficiency or defect in the transporter protein MRP2. So we have already conjugated bilirubin, but the problem in the secretion. So there is increases in the conjugated bilirubin, and we have conjugated jaundice. In the third type of the jaundice is the post-hepatic jaundice, or what we call obstructive jaundice. And in this state, we have biliary tract obstruction. There is, after conjugated bilirubin secreted into the biliary system, there is obstruction. There is mechanical obstruction leading to conjugated bilirubin doesn't reach the intestine, and urobilinogen not produced and absent in the urine. Since the conjugated bilirubin doesn't reach to the intestine, so there is no urobilinogen, and it will not appear in the urine. And usually in the post-hepatic jaundice or obstructive jaundice, we have dark urine because the conjugated bilirubin is water soluble, so it appears in urine, and the conjugated bilirubin is the bile pigment, so we have dark urine. Also, we have pale stool due to absence of sterocopilin, which gives the stool its characteristic color. So we have pale stool. And there is also increasing in fat in what we call steatorrhea. And increasing fat due to, since one of the bile function is fat digestion, and there is obstruction, and the bile, it doesn't reach the intestine, so there is a decrease in the fat digestion, leading to increases of fat in the stool in a disease called steatorrhea. So what are the causes of the post-hepatic jaundice? The post-hepatic jaundice causes, there are three causes, either intramural, mural, or extrinsic. In the intramural, which means inside the wall, so the cause of the obstruction is inside the wall, like what happened in choledocholithiasis, due to presence of a stone inside the common bile duct. This is called choledocholithiasis. So this is intramural, if the cause was intramural. The second cause is the mural, and that's mean the problem in the wall itself, not inside, in the wall itself, like what's happening in the biliary structure. If we have biliary canals structure, or primary sclerosing cholangitis, and in this disease there is a structure of intra and extra hepatic canals, bile canals or bile ducts. So in this state there is problem in the wall itself. In the extrinsic, the third cause of the post-hepatic jaundice is extrinsic compression of the bile duct. So there is compression of the bile duct from outside, like what's happening in the pancreatic head carcinoma or lymph node enlargement, especially inside the porta hepatis, or what's happening in the Merisi syndrome. And the Merisi syndrome is the stone found in the gallbladder neck, but it's large enough to compress the common bile duct. It's large enough to compress the common bile duct. This is Merisi syndrome. So the compression from stone impacted in the neck of the gallbladder.